Good morning, good day, good afternoon, good evening to all participating in our webinar, How to Involve Partners in the Treatment. My name is Annamaria Giraldi and I'm the president of the ISSM. And I would like to welcome you all today to this very exciting topic. Can I have the next slide? So just before we get started, for those of you who do not know ISSM, I just would like to say that we have a vision that every human being has a right to a healthy and satisfying sexual life. Can I have the next slide? So the purpose of us is to be the most respected and trusted source of information, education, and professional development on human sexual health through the delivery of world-class publications, research findings, online and in-person opportunities for knowledge exchange worldwide. And our webinar series is really a big part of how do we reach all you working with sexual health over the world and a part of our mission and vision. So thank you for being here. Can I have the next slide? I also want to thank Patricia Pasquale, who is the director of our webinars and the education committee, who put so much work into working with this webinar series. And we have representatives from all parts of the world in our education committee. And as you can see, they represent our affiliated societies because ISSM is built up of societies in all parts of the world. We have affiliated society in North America, South America, the Middle East, Europe, the Asian Pacific region, and South Asia. And also we are affiliated with ISSWIS, the International Society for the Study of Women's Sexual Health. So we are really covering all the world, and usually we have members from all continents in our webinars. Next slide. If you are a member of ISSM, there are many benefits, but one I really would like to highlight is that you get access to our 4 journals. We have 3 paper journals and 1 video journal. The video journal is of prosthetic urology, and then we have Journal of Sexual Medicine Open Access, and Sexual Medicine Reviews, where you can get access to the newest research done in sexual medicine. Next slide. So having said this, and if you're not a member, I really would encourage you to become a member of society. It's a pleasure to introduce our moderator for this webinar. Chris Nelson from the United States is Chief of the Psychiatric Service and attending psychologist in the Department of Psychiatry and Behavioral Science at Memorial Sloan Kettering Cancer Center in New York. And he's also a professor of psychology in the psychiatric department at Weill Medical College of Cornell University. And Chris is also involved in the North American Society for Sexual Medicine. So a warm welcome to you, Chris. You have a very busy schedule, so I'm so glad that you took the time to moderate this webinar. Welcome, Chris.
Yeah, thank you, Annamaria. And really, it's my pleasure to moderate the webinar. And I really want to thank ISSM for, selecting a topic like this because, partners are not, we don't talk about partners enough. And really important to think about how we involve them in treatment. As we know, involving the partners in treatment can really improve the efficacy of our treatments. And so very excited for this webinar today. And let me just give you an overview of how logistically it's going to run. So we'll have our 2 presenters and they will present their presentations. And so after that, we'll have probably a good half hour for questions and answers. And so we'll have the 2 presenters, they'll both present, and then we'll have questions and answers after both those presentations. In the questions and answers, we really do encourage this. Please put the questions and answers in the Q&A button down below. And so the Q&A button as opposed to the chat button. And so when you put those in the Q&A button, we'll be able to read those. And then once the presentations are over, we'll hopefully have a chance to go through each one. So without further ado, I'd like to introduce our first presenter today. And she will present on the role of the partner in sex therapy, and it's Katia Oliveira, and she can tell me if I pronounced that correctly or not. But she's a PhD, is an assistant professor, a cognitive behavioral psychologist, and supervisor, and a sex therapist. She develops research on the topics of sexual health, namely sexual problems. Through the years, she's maintained professional training at the clinical level, especially in several CBT approaches, namely mindfulness and the third wave of CBT. She is a main researcher of the research group in human sexuality, faculty of psychology and educational sciences at Porto University, and a collaborative member of the HEI Lab, which is the Digital Human Environment Interaction Lab. And so, Katja, thank you for presenting today, and welcome, and we're looking forward to your presentation.
So thank you, Chris. It was okay, my name. So hello, everyone that is present here from different parts of the world, as I understand. And I would like to start thanking to give a thanks for the invitation of being here. It's an honor to being part of a webinar of the International Society for Sexual Medicine. And it's also very honor to, pardon my English, I'm not used to talk English every day. So also it's an honor to talk about one of my passions, that is the clinical intervention with couples and with persons individually. So I would like to change. Thank you. I will start with, it's impossible for me, you know, this is something that it's scientific valid, everyone knows it, but everyone forgets about it, especially our patients. But I would like to talk about how sexuality is related to health and well-being, how sexuality and the desire of intimacy are essential factors to human development and health. And of course, this is connected with what Annamaria told us in the beginning. But somehow I feel that this is an idea that's still not assumed in the everyday basis of the person and the couple that asks for help, and also many health professionals. So with the automatic pilot of the day, with the difficulties and the pressure of the day, we tend to forget that sexual response is complex and it's a combination of interaction of different factors. And this concept is very important in the treatment of sexual and relationship problems, and we tend to forget this, and it's impossible for me not to start by here, because it has several clinical implications in the treatment. Can you change the slide, please? Thank you. So, well, I started by, of course, doing a revision of what the literature says about the partner and the influence of the partner, and of course, but then I started to think, well, let me bring my ideas also and my practice. That is one of the things that I do most in my week. And I hope to give you both dimensions, and then in the question and answer part, I of course open to discuss more the details of what I'm going to present. And well, the literature is very heterogeneous, and there's not so much about, there's not so much research about the implications of the partner, or the factors, or the influence of the partner in the treatment of sexual functioning and relationship factors. But, and most of the observations are in clinical reports and clinical reports of clinicians, but there is a common fact that there is no doubt that there is a significant link between sexual and relationship functioning. And although it's not clear what comes first, so we don't have a causal direction of both, honestly, I'm not very worried about it, because in our clinical practice, we should assume that they are both connected and interact, and we should talk and intervene in both of them. So I think that's the most important thing, and what I would like to tell you, all of you, is that if you are a clinician or if you are a researcher, there's no doubt that when we involve both dimensions, we get better long-term therapeutic results. Okay, so continuing with the slides, it's very important to think about sexual problems as multi-causal and multidimensional dimensions. So we have to think about individual and couple issues, values, culture, education. Also, we have to talk about love and intimacy, that in most cultures, there are specific ingredients that people assume that are necessary to have stable and happy and significant relationships and intimacy. So this can be, it's if it's hard to do individual therapy, the couple therapy really gains a great complexity, but it's also very rich to make the puzzle how a couple functions and how a couple can work together for a better life in general. So we have also to consider when we are, even when we try to convince a partner to come to the session, that we have changes in many of our cultures. Not it's different from culture for culture, but we are changing from a repressive and timid culture to a habit and performance direction for many cultures. This is not really good, and this creates a lot of discrepancies that I'm going to talk next. Also, we have a lot of sexual problems that creates conflict avoidance, and that really plays a major role in the couple's stability and intimacy. And the reduction of this intimacy and sexual contact, it's a risk factor for the partner's sexual dysfunction. And this is a very subtle thing, and sometimes it's very subtle and very hard to address when we have the luck of the couple coming to the sessions, because somehow I feel that the partner that comes with the partner with a problem really assumes that eventually the problem that he can present in terms of his sexual functioning or sexual response will go away if the partner resolves the problem, or probably it's difficult also to share, because I have the experience of some people don't want to share it because they don't want to create more sense of guilt or more pressure to the partner that came with a problem. So, but this is very subtle and very important, because most of the times the couple is very restricted in terms of sexual activities and sexual satisfaction. And of course, other variables are not really okay in the relationship. So this is very important when this is a reason why we want both partners in the session, because we have usually a lot of loss of intimacy, loss of life satisfaction, a lot of emotions that are negative, the feeling of being unattractive, psychopathology in general, the loneliness, and let me tell you, being alone as we share the bed with our partner it's very hard, the sense of guilt and the sense of rejection. Also, I would like to point that sometimes the person doesn't come because the treatment may be a problem for equilibrium that usually the couple can have in the middle of the problem. So a comfortable but negative, we know, equilibrium, and this can be very stressful. So next slide. What are the common difficulties in involving the partner? Usually what I find it's a recently formed relationship or casual sexual partners. Here the literature is very clear, although it's not very vast, but it's very clear that even if it's not a very long relationship, we benefit of having the partner even in 1 or 2 sessions in the couple, because it gives us a perspective perspective of the person who comes to the session and wants to resolve a sexual problem. Also, sometimes the partner has a really difficulty and it's very hard to expose the intimacy, and he or her is afraid of being blamed or worry about also the effect of the therapy in the relationship. People changing is very difficult. I usually say this, whatever it is, and because we cannot predict really the results. So there is a lot of fear around this. Also, we have more practical things like agendas, geographic problems, family lack of support, for example, for being both if there are kids, or economic impediments. I don't know in other countries, but in Portugal, doing a couple or sex therapy may be more difficult economically than being in an individual progress and individual therapy. So then I would like to highlight two more subtle things that I find in my practice. One is the partner lack of attraction. That is, it's something that I feel very difficult to work. We don't have a lot of research also working on this, and we still have a gap between couple therapy and sex therapy that doesn't benefit the treatment of all these difficulties that are interconnected. But the partner lack of attraction and difficulty of working and to talk about this is usually an impediment. And also the presence of extramarital relationships that usually one of the partners doesn't want to leave this relationship most of the time. So probably other things would appear in your practice. So next slide. Why do we need to involve the partner? And one of the major factors is sometimes, and I'm talking here more in my experience, but the literature also points this, the excessive medicalization of sexual problems. Of course, most of the time, sexual problems need a multidisciplinary team working and needs medical assistance. But there are some articles that are very interesting of the effects, even when we start with a medical treatment, the importance of the partner being and to adjust to temporary or more long-term changes in the sexual response of the partner and the couple, of course. Also, this doesn't help when the partner is absent, the non-acceptance of a shared problem point of view. So the prognostic is very reserved when one of the partners thinks that the problem is her or his and he has to resolve it. And it's a shared problem and we need to work this. Also, there is a resistance from the partner in collaborating in the changes of the sexual and relationship dynamics affecting the results. So if we don't have both, we have more probability of having results that we can achieve because of this resistance. And also the maintenance of avoidance and conflict patterns, negative communication, lack of intimacy. Also, next slide. Also, the maintenance of several structures and processes that are emotional and cognitive, and that indirectly may influence the partner and the couple. Also, maintenance of sexual dysfunction and psychopathology. And most importantly, I think this is very important, the discrepancies that until, it's normal for two persons to have discrepancies, but we have to find a middle term for both of the partners. So usually we find this discrepancy in sexual desire, sexual frequency, sexual attitudes, sexual competences or behaviors, and we need to address this. And of course, if we don't address, we have more risk of relapse. So to entering in my last part, change of slide, please. What can we do to involve the partner in therapy? Well, here we have the real and realistic. If the partner doesn't come physically, we can try to contact by phone. I usually say, if we can bring the partner one time, we really we really can have a higher probability of this partner coming in the therapy, not immediately, but during the process. So usually I ask the person to, if I can talk to her, come one session without compromise. You don't need to compromise with anything, just come. And usually this helps to resolve myths and beliefs and about the treatment, about the psychologist, about what is expected, and usually it goes well. We also may be flexible with online sessions or being creative in bringing the person to the session. And if he doesn't come, or her, we can we can give materials and have an indirect intervention. We can have an intervention with the person that comes. We can try to model the communication of the person with the partner in terms of etiological factors and other information. Also trying to put the problem in perspective and working misunderstandings and to propose strategies for change. And most of, and very important, because we don't talk only about patients, but we talk about the health professionals, we have to speak about the limitations of not having the partner. And research shows a reserved prognosis in our experience. So this should be communicated, should be negotiated, and being careful of not causing, also being careful of not doing more harm than good, you know, and this is really very important. And most for the technicians and the health professionals that are here, we should really work with our ethics, of course, but also with our personal limits. Sometimes we are difficult to say no. We don't take care of us as professionals, and we should stop and negotiate and think with the couple or with the person what is the best way to treat. But next slide. Also, the partner can be in the session and not be present and not collaborate. And here, of course, who works in therapy knows that we have a lot of strategies to try to motivate and to try to bring an acceptance of the problem to the session. So the validation of both members' needs, expectations, and limits also, and this idea that both of the partners are responsible for the treatment. There is no guilt. The partners usually do their best, and the couple, but the responsibility to bring this treatment to the couple, it's from the couple, you know. So also we have to have an agreement between the therapist and the couple, and also being realistic about this treatment. Sometimes we are very close to our protocols and we forget to being realistic in the context of the couple. Training, coping strategies, problem solving and communication skills, and also promoting one of the things that I feel that's most important in the motivation, that is promoting skills of non-sexual affection and couple general quality of lives. Remember the love and the intimacy and other relationship factors that we have to consider, and this sense of the life, you know. Sex, it's not a independent thing that we grab when we are okay. Sex makes parts of our lives, and so we have to look as a big picture. And also working on possible adjustments to new variables in sex life that can be the use of medication, chronic disease, physical limitations, and other things. So to finish, because I'm passing the time, but I'm already finishing. Next slide, please. The take-home messages could be many, but I think the most important thing is that there is no right or wrong. Sometimes this is very scary in our profession because we don't have a net, but also it makes it very interesting and it's a puzzle to resolve, and there is no routine in our work, but there is no right or wrong. So every case is a specific case, and every person and couple has their own issues, and we have to, as a therapist, should be curious and become passive and creative and flexible in adjusting the treatment guidelines to patients and couples, and just one of the things that I recommend is no elephants in room. And this, it seems easy, but sometimes it's not easy in a therapeutic context. You know, it's hard to say the difficult things. It's hard to talk about our limitations also as therapists. So the best thing that I recommend, no elephants in the room, and being flexible and to discuss with our patient and being human, and probably everything will be okay. Even if we are not the persons that are going to help, we can give directions to other specialists or for other ways of treating the problem that not, in my case, psychology. So I'm finishing. I hope this is, it's too quickly. I hope that people could understand. And of course, I'm open to questions at the end. So thank you.
Yeah, thank you for that wonderful presentation. And just a few comments where this presentation is amazing and super helpful. So even though a short time, I think well done. So thank you very much. And now we'll turn to our second presentation. And presenting this will be Dr. Sharon King, who is on faculty as an assistant professor at the Medical College of Georgia at Augusta University in the Augusta Veteran Affairs Medical Center. She completed doctoral medicine degree in a urologic surgery training at the Medical College of Georgia and a sexual medicine fellowship at San Diego Sexual Medicine with Dr. Irwin Goldstein. I think a lot of us know Dr. Irwin Goldstein. Yeah. Her clinical interests include erectile dysfunction, male incontinence, prosthetics, Peyronie's disease, and female and male sexual dysfunction. Dr. King prides herself on taking time to not just assess her patient, but look at the couple as a whole to rebuild intimacy in their relationship and training the next generation of urologists. So Sharita, very nice to have you here and look forward to your presentation.
Awesome. Well, thank you for having me, and thank you, ISSM, for inviting me to go through this talk. And so I will be discussing why I think it's very important for us to include patients, partners into the IPP discussion and how I do it in my practice. I am very passionate about this topic, as evident on my website. As Chris just read out, I pride myself on looking at the couple as a whole. I want to figure out how can I rebuild this intimacy within their relationship. This passion is part of my pedigree. Next slide, please. And I had trained with Dr. Goldstein, as he stated, and his wife Sue at SDSM. This is my fellowship family here. And here we learn not only about male sexual dysfunction, but female sexual dysfunction. And that taught me new ways to be able to improve partner and patient outcomes when we're talking about penile implant surgery. Next slide. That's why it was a shock to me when they asked me to debate Sue at the virtual SMSNA in 2020. And I was given the position why partners should not be involved in penile implant surgery decisions. I did a very tongue-in-cheek debate. I made the most flimsy arguments, assuming Sue would win, but I actually won. And the fact that I won, it elucidated to me the views of many of my colleagues. But my question was, why are we so reluctant to involve partners in this discussion? Next slide. So I think one of the reasons why is because partners have gotten a bad rap. They have a lot of negativity associated with them. My fellowship sister, Rachel Rubin, gave a rousing talk at the 2019 SMSNA in Nashville, where she was given the topic to discuss how to deal with the partner of a man with a partner of a man being treated for ED. Her response to this was to deal with had a very negative connotation, and she implored the audience to think differently about the partner. Next slide. After all, let's remember, ED is a couple's disease. It does take two to tango. In most cases, our patients are going to want to use this erection with another person. So why wouldn't we bring them into the fold? Next slide. So there have been studies that shown, like this one, that patient satisfaction actually correlates with female partner satisfaction. So it's important that most of the stuff that the research I talk about today is with female partners, just because of the lack of validated questionnaires for homosexual male partners. But if we know that the patient satisfaction is going to be correlated with the female partner satisfaction, wouldn't it behoove us to include the partner into this discussion? Next slide. So this is a review article. It looked at different factors that affect patient satisfaction, and they identified 3 categories: pre-op, intra-op, and post-op. And when you look at post-op, partner satisfaction played a huge role in the patient satisfaction. Next slide. And then this article that was in the Journal of Andrology, the International Journal of Andrology, and it also had editorial comments in the Journal of Urology. They sought out to investigate what's the effect of penile prosthesis on the sexuality of the patient and the partner. They wanted to know who was more satisfied. So they took 20 patients that had penile prosthesis from 2013 to 2018 and their partners. They had them complete the ASEX, which is the Arizona Sexual Experience Scale, prior to implantation. And then after implantation and they used it, they had 20 patients and 19 partners complete the ED inventory of treatment satisfaction and the ASEX at 6 months follow-up. Next slide. And what they found is that the sexual satisfaction was actually higher in the female than the male patients. This wasn't statistically significant, but I still think it's very important to remember this. I think one reason why is when men have a more strong erection. So when it's more rigid, it's able to glide more easily. It's not like they're trying to stuff rope into a canal. That way it's more comfortable for the patient. So therefore they probably enjoyed it a little bit more. So the question is, if we stand to change 2 different lives with this procedure, why not have both parties in the discussion? So the next question is, how do we start this discussion? Next slide. The first thing to remember is to never assume. And when I say that, I mean never assume anything about the patient's partner, their gender, their age, their race, not even the relationship status that the patient and the partner have. To me, this is like asking a woman if she's pregnant. If you assume wrong, you're going to alienate your patient, and then they're going to withdraw from the process themselves. The way that I go about this is asking open-ended questions. So I ask my patient, hey, tell me about your partner. And then I become an active listener and I record their responses in the chart. The reason for that is so when the partner does come, then you have a reference and you can go back to it. So that way you can talk to the partner as if you already know them. I have found that this has improved patient engagement because I am showing them that I have a vested interest in them in their relationship. The other thing to remember is that we should have an open mind. If you look at this picture, it shows the wide range of relationship statuses and the way relationships can look. It is not up to us to judge our patients, and we need to keep an open mind so we won't alienate our patients or their partner. Next slide. So now that you know who the partner is, it's now time to invite them to this talk if they haven't already been present. But you have to remember, this is not the last step. It is not enough alone to go ahead and just have the partner there. You must engage this partner. To have them as a fly in the wall in the room is not very helpful. This may be why partners get a negative connotation, because they're brought in and then ignored. This in turn will alienate them and will make them despondent. So why is it important that we want to include patients, partners in the conversation? Next slide. Next slide. Yep, perfect. All right. The reason why, because partners can be the gatekeeper. I mean, you can pick your poison. They could be your biggest ally or your worst enemy. Just remember the old adage, happy wife, happy life. I know I just said don't assume anything, and I would say partner, but it doesn't quite have the same ring. And the thing is, if you ignore them, then they can halt the progress of the patient getting to the OR for the implant. Next slide. So how have I found that partners can be allies in my practice is, one, they could be a historian. A lot of times they'll bring information to the table that the patient has forgotten, whether it be surgeries, medicines that they take, or just information about when the erectile dysfunction actually started. The other thing is they can relay embarrassing information that the partner would not want to say themselves out loud. For instance, a lot of patients are in denial about the fact that they have erectile dysfunction. And you'll ask them, hey, Mr. X, how are your erections? And they'll be like, oh, they're fine. But you'll see the partner in the corner like, they're not okay. The other thing is they can be a fact checker for some of these stories that the patients are telling us. I know we've all had the patient who came in and said they used to be 12 inches and now they're 6. The partner can let you know that if this is true or not, which more than likely it's not. The other thing is they can be support for the patient themselves. Even though these patients are seeing us for erectile dysfunction, once we tell them that their erectile dysfunction is severe enough that they're going to need a surgery to correct it, a lot of times some of these patients will still go through mourning of their erections. And it's nice to have somebody there that can help them through that. The other thing that I have found that they can help calm anxiety that the patient may be having about upcoming surgery. The other, another thing that I like about having partners in there is they are a second set of ears. So I know we throw a lot of information out at our patients once we're ready to set them up for surgery. And a lot of that stuff goes in one ear and out the other with our patients. But it's nice to have another person there that can recall some of the things that were said during the visit. They also, I have found in my practice that most of them will be providing post-op care for the patients. So it's important that they know what to expect before going to surgery. So that way they have stuff set up at home. When the patient goes home, they already have their ice packs, they already have their scrotal support, things that'll help them have better outcomes. And it's better that you meet them prior to after the surgery and you're just meeting them in the surgical waiting room. And then lastly, I've found in some patients that have dexterity issues, it's good to have a partner who is involved because then they can help with post-op cycling. Next slide. So now that you've found out who the partner is, you've invited them to the conversation, but yet they're still kind of withdrawing from it. Now it's our responsibility to try to figure out why. And you want to ask them about their sexual history. And the reason why you want to do this is if we look at the PRESIDE trial, it showed that the prevalence of sexual problem with distress is approximately 12% of any type of dysfunction. And then furthermore, we have to remember that most of our patients are older males who may have older female partners. Next slide. And so in 2016 at the AUA, I presented on partner prosthesis panic, where I discussed why women have a deer in headlights look when we're discussing prosthetics with their partner. Next slide. What we did is we looked at the last 50 IPPs that were done in men in heterosexual relationships. We found that 11 of those female partners, which was 22%, their mean age was 57, expressed that they had partner prosthesis panic. So once we identified these women, we were able to treat them at SDSM through a biopsychosocial model. Next slide. So what we found was that all of the women were either menopausal or perimenopausal. All of them had FSD for greater than 5 years prior to their IPP, before their partner had their IPP. And then all of them had an abnormal FSFI and sexual distress scale scores. Next slide. So when we went through the biopsychosocial model, we had our psychologist that's in-house look at them, and we found that 27% of these women had a history of sexual trauma and abuse. 45% had mood issues. When the pelvic floor physical therapist saw the patient, they found that 73% had abnormal pelvic floor physical exams. And then when we did our exam, the vulvoscopy, we found that all the women had evidence and symptoms of genital urinary syndrome of menopause and other abnormalities. So once we were able to find all these issues in these patients and these partners, we were able to treat them. And then that prepared them to receive the erection that their partner has now that we put an IPP in them. And in doing so, we have increased the outcome or bettered the outcome for both of our patient and their partner. Next slide. So the next thing you want to do is ask them, why are you afraid? What are your concerns? And I try to get them to give me all the reasons that they have concerns. And then I will systematically and completely dispel all their fears through education. My goal at this point is to demystify the implant, to show them that this is something that we do routinely. I know it's routine for me, but not for you because you're in this situation for the first time. But try to give them information so that they feel more comfortable with what we're talking about doing. The other thing that I do is I use patient advocates and educators. One of my patient advocates' wife will actually talk to the wives of patients that have upcoming surgery. That way she can discuss with them what it's like to be with somebody with an implant, like how to take care of somebody after surgery of an implant. And I have found this to be very invaluable in my practice. Next slide. So what if you've done all of this and you tried everything you can possibly think to do and they continue to say no? Then that's when sex therapy, I think, comes into play. We just had a great talk from Katia, and at this point, there are probably other things that are at play that you just don't know or understand. And I know a lot of times we play therapists in our visits with our patients, but at this point, it's time to get a professional involved. Next slide. So these are my take-home messages. First, never assume anything about the partner. Ask about them and be an active listener, and let's not be judgmental. Next, you want to form an ally with the partner. You want to do this by including them in the conversation, and also by treating or sending them somewhere to a practitioner that can treat the partner's sexual dysfunction. Then you also want to dispel any fears of surgery. And if we do all these things, our patients will have better outcomes. And you won't have the scene here on the slide where the patient is like, yes, please sign me up. And the partner's like, absolutely not. Next slide. And that is it for my portion.
Okay, wonderful job. Yeah, thank you for two really excellent presentations. And Katia, do you want to turn on your camera and unmute yourself? And so we do have some questions, but I just want to thank you two again. Really, again, excellent presentations and really some very good information, education about partners and really the importance of including partners. And so I'm looking at some of the questions. So so this question I think was for Dr. Oliveira. So the question, let's see, what advice, how would you manage if there's a big difference in sexual desire and mismatch in fantasies and preference between the couple? And so that's the general question. Then is separation a solution, or polyamorous relationships or multiple relationships, multiple sexual partners a solution?
Okay. So first, I'm going to be a little bit irreverent, as I am usually with the patients in some timings. Separation is always a solution, and couple therapy and sex therapy doesn't always bring the couples together. Sometimes it helps couples to restructure and to go on with their lives in a most adaptive way. But of course, that's our major goal is, and usually when a couple comes to the sessions, is to try to get closer and to have a good relationship. So I'm not thinking about separation now in my response, but I think that, of course, that's when there is a big mismatch and a big difference in the couple in terms of desire, in terms of sexual preferences. This is not very good. It's not a very good prognostic factor. But also we have to understand if is there something always present in a relationship, or if it's something more from a part of the life of the couple. And of course, if it's always present, it's worst. And if something provoked, I'm thinking about a child that's born is something very common, then the prognostic is better. here, what I would, well, the main thing that I work, it's the main goal of the couple, and to get a compromise from the couple to work through the goal and work through the process, and maybe taking some pressure of the final goal then, and to work with the process. And here, I think it's very possible for the couples to develop themselves in terms of their limits, in terms of their flexibility, in terms of their openness to new behaviors. But also, if I think about the partner that is more active, sexually active, or has more preference, or has more excitation, here we also have to work a way of regulate that emotions and that needs. So we have to find a common ground, a middle ground between them. And if they both work and they both are motivated, then we will find a way, and they will find a way. And if I think about couples where this happens, it's very funny, because the tendency is, at long term, the person who is more inhibited becomes more naturally open to sexuality. Of course, don't forget about other relationship factors, sometimes agenda, sometimes help with the family and help with the kids. And so don't forget about the practical things of life. But if a polyamorous relationship or polygamy is, if allowed, a solution, it's always a solution if everyone is okay with that. And sometimes couples are okay with that. And sometimes one member of the couple has to think about it, and the couple has to work together in order to that become possible. It's not good if it's a secret, no elephants, but sometimes it's a solution. And there are couples that assume, I want to be with my partner in a wedding and we are very happy and everything, but he or her needs something else, and I'm not capable, but I'm hoping for him to experience with another partner, but no secrets allowed, So it can be a solution if everyone agrees, of course. But it usually there's a lot of working with beliefs and conservative and cultural norms, that's even if we are open, be prepared, because then in the practice things are not as on our minds, in our fantasies. So there's a lot to work to do.
It seems like the key there then is having some agreement, like you said, no secrets, right? Having some agreements and so I'm in New York City. I'm in New York City in the United States, and there's a large gay male population here. And so I work with a lot of gay couples, and I work a lot with men after prostate cancer. So I'm at a cancer center. Yeah. And so I work with a lot of couples who have been couples for 20, 30, years, whether they're straight or gay. And certainly, kind of in my experience, gay men couples actually are much more open to this idea than heterosexual couples, and it's that agreement between the two, and it can actually be. I've seen it work out really well for relationships.
I think that gay couples are in their history and our cultural history. They were so obligated to be close that the evolution is to be open and to be truth about what we want, what we need, and it's a counter effect. That's my perspective. So yes, I also feel that in gay couples, they are more open and more soothed with the idea. It's more open, a real openness to it. Yes.
Yeah, great. Yeah, and I'm just going to skip around to some other questions here. But come back to some of the questions. So I'll kind of not go in order, but I'll skip around. But for Dr. King, is it possible? So this is a question: is it possible to experience orgasm if the erection occurs thanks to a penile implant? Is there a relationship between the physiological erection and erection by implants with the capacity to experience an orgasm and/or ejaculation?
Okay, so one thing that Goldstein used to always tell patients was like, can you ride a bike? before I put an implant in? And then they're like, yeah. And I'm like, well, you can ride a bike afterwards. So if you were able to have orgasm beforehand, you should be able to have an orgasm afterwards. It doesn't really change your capacity to have orgasm. Now, the reason why you have erectile dysfunction may change whether or not you have ejaculation, which is different and separate from orgasm. But you should be able to orgasm.
Yeah. And then there is the experience with an implant, right? So a man can have an erection with an implant, but not be sexually excited, right? It is possible to have an erection and you have not much sexual interest. And so that erection or that orgasm may not necessarily come all that easily, or may be delayed, or.
Yes, yes, that is true. And then the other flip side of that is we do have patients who decide not to go through with implants, and they still have full sexual lives because they're able to orgasm regardless of having an erection or not.
Yeah. And that's an interesting point as well, right? So men can have an orgasm even without an erection, and it's a big surprise to men if they have difficulty with erections and find that out, because they've never been in a situation before that, if they could have erections, where they would actually have an orgasm without an erection. So.
Yep. Yes, exactly.
Yeah. And so then I'm going to, again, skip around. I'll go back up to Dr. Oliveira. And so here is a question. So how do you deal with a third person in a relationship as an elephant in the room?
Okay, so here the main principle, and I agree with it, is that if a couple is working in their sexual relationship, and in a couple relationship, there are no secrets allowed. So if there is a third person and this is a secret, usually we start. Well, it depends how the couple presents. Sometimes the couple comes in the first session together, or it can be one person comes individually, but usually in the individual session that we do, after, even if we are with a couple, we try to establish taking the elephant of the room clearly, and trying to help the person to do that if he or she needs that help, doing in the session, doing it at home, being supportive, being attentive to crisis situation, because we need sometimes to act outside our session if there is a crisis. But if the partner doesn't want, or if the person doesn't want to talk about it, and there is an elephant, I will not give the couple or the sex therapy. It's not possible. So there's no doubts there.
Yeah. So if one person has a secret, right, or the elephant in the room, and they're not willing to talk about it or disclose it, and so certainly this has happened to me at times where a patient, alone will disclose something, but then not with a partner. So at that point, then you would not engage in partner or couples therapy or sex therapy at that point.
If the objective and the main goal of the couple is to get connected, and if the other member isn't allowed to know or to adjust to it, or to, I think there are a lot of, well, this is a principle of couple therapy also, it's not mine, but I agree. Of course, there are, let me tell, sometimes there are persons that come with the other partner, and it's a secret, but comes to sex therapy with the person that there is sexual involvement, and this is different, So here it's the goal is to have good sex life with that person, and then I'm not supposed to judge. I don't judge, so it's not a problem. But if there is a couple that wants to work together and there is a secret of this nature, it's not. And I agree that people should have their black boxes. Our partners don't have to know everything, so it's allowed. But this kind of secrets, it's not. Research shows that also.
Yeah. Good. Yeah. Interesting. So interesting, provocative questions, provocative,
Can I add a comment? Because I cannot use the chat. I think it's also unethical if the therapist and one knows that there is an elephant, but the last person doesn't know about the elephant. So it's a very unethical thing, in my opinion, that the secret is there, and when the third person will find out, I mean, it's a terrible thing.
Yes.
Mm-hmm. Yeah,
I agree.
And how, like, just thinking about this and kind of so sometimes if there is a secret about, one of the two of the pair is having an affair, they don't want to disclose that because they don't want to hurt their partner, right? They don't want to damage or hurt their partner. How do you
well, that is I think that's a false question, because probably the couple is already hurt and the person is indirectly hurt by this relationship, because it's my experience, when people have these secrets, they also change things in their interaction and in the family and in the relationship. So, and as Annamaria said, it's ethical, so I think the secret here is also being very compassionate with this person, because being afraid of hurting, it's very natural. And I think all of us can agree or to think of something of us that also feels something parallel to this. Like I have to say something very difficult that I'm going to hurt. The fear of hurting the other person is a very natural thing, but we have to put the person to think about the pros and cons of that, and at the end, how we want to be and how we want the other person to be also, and what kind of information we want that person to have. Because even if imagine the worst scenario, we are not in love anymore, we don't really want to be with that person, even if it's something that we cannot be total acceptive of that. We have the responsibility of letting the other person go and to adjust to a new relationship and a new life, not living in a secret. So that's the work that I would do. And I think the secret is being very compassive with the person that has a secret. And being compassive, it's not something that we try to do it. We have really to feel it and to help the person. Okay, we are here with you, and the fear is normal, but what we want to do, our values are what you want to be really, and what do you really want to that person that you are having a secret.
Yeah, great. Yeah, interesting discussions. Really important, right? To kind of working with couples and how we help them and how we help.
It's very difficult for us also, because we balance a lot, and we feel also very precious sometimes. I feel very precious sometimes. What will I do with this? And yeah.
Good. And so transition back to Dr. King. So Sharita, you have this concept and presented this poster on partner prosthesis panic, which is really an interesting concept. And so there's one question to kind of just summarize what that is. And then I guess my question to that too is, you can think about it as partner implant panic, right? But even if you're treating erectile dysfunction, right? Partner Viagra panic or partner PDI5 inhibitor panic.
Partner erection
panic. And so, maybe talk a little bit more about that. And like, have you done any work with just, again, erection, the first line treatments for erection? And because it was really interesting kind of how you mapped out, treating the partner is such an important piece of that.
So partner prosthesis panic is a cute term that we came up with at SDSM. And we felt like it kind of, like I said, encompass that, like you start talking, you've been there, you talk to the patient and their partner sitting there, and you're like, oh, I'm gonna give you this rock hard erection that's going to work whenever you want it to, as long as you want it to. And the females are going to like, oh my God, like you can tell she she is expressing her fear on her face. And that's what that panic is. And basically, like I said, what we found was that most of these women are either menopausal or perimenopausal. And if you just treat those issues, you're going to make them ready in order to be able to receive said erection. And do I do this for other patients? Yes. If anybody's coming in with erectile dysfunction and the partner's there, especially if it's an older female, I always ask them, hey, are you using any hormones? Have you ever tried like topical hormone creams? Are you seeing a GYN specialist? If not, I welcome them to my practice as much as I can. We're getting pretty busy, but I try to treat as many people as I can, just so I know that my patients get a good outcome. And then my new patient is also going to have a good outcome from this. Because what's the point of me giving a man an erection if he can't use it when he wants to with the partner that he wants to? Now, again, it's not my judgment that, like, if he decides to go elsewhere, and that does happen, that's not my judgment, but I try to help the couple so they're both ready.
Yeah, and right, and so this is why we see the importance of the partner, right, and the importance of these types of presentations and talking about these. And so this is a question that really for both of you. And this is from Helen Burney. And so great presentation, Shrita, and a great presentation, Katya. What advice do you give when a partner won't come with a patient, and the partner reports the patient reports the partner is not interested in sex at all? Is there anywhere to go with that? Is there, like, is that just a dead end? Do you stop there? Or,
I think it's a very touchy subject. And I try to be compassionate with the patient, and I try to encourage them to come. I have talked to partners on the phone and be like, hey, this is Dr. King. I really would like you to come. So that way you understand the disease process that's going on with your partner, because a lot of times the reason why they don't want to come is because they think it's all in his head, or they have guilt associated with it, or they are internalizing their erectile dysfunction to them and thinking it's their fault. So I just try to coax them the best way that I can. I can't hog tie anybody and make them come to my visits, but I just let them know that I truly do want them there, and it's just not their partner being like, hey, you need to come to this appointment with me. I have talked to them on the phone before.
You have. So you've actually reached out to them. Mm-hmm. Yeah. Interesting. Yeah. Good. Yeah. Katya. Yeah.
Yeah, I agree. I agree also. But I think here this is tricky because sometimes I find that when a partner doesn't come, when someone comes to our office and says, my partner won't come, we usually assume that the partner really, that they really talk about this as it is, and the partner really says, I will not come. And most of the times what I find out, in my experience, I found out later, is that there wasn't a good communication and the partner really didn't say no, I won't come. So most of the times the partner doesn't come because bad communication skills and the not good problem solution and coping strategies between the couple. So this can happen, and we must be aware of that first. Of course, that really the partner can really say, I will not come. And this will not allow probably a good results in terms of the couple. And even if the person is not with desire and not interested, well, here what I will have in my session, it's individual therapy. Mm-hmm. And when we do individual therapy, we take care of our patient as one and his needs or her needs and what it's important in terms of goals of life, of sexual goals and other things. And here then everything is possible, framing the person that is with us. There is a shift here if the person comes along.
to speak to that point about when they're not interested. So then again, that's where that biopsychosocial comes into play, right? So it's just not like, so yes, there may be some psychology to it, but there may also be like a pelvic floor issue, or it may be a medical issue, something else that needs to be treated. And that's why they're not interested. We got to try to get to the bottom of why are they just saying no, basically.
Yeah.
Yeah.
And is there like, do you have any advice, like tips, like, you know, for a partner who comes in and who's not very expressive or seems to be uncomfortable or doesn't seem to want to share? Like, you know, how do you, you know, for both of you, how do you get them to open up? And you're coming from different perspectives, right? And so Shrita, you're talking, you know, you're coming from a urologist perspective where you're potentially talking about, you know, you're really talking about treatments, right? And, you know, Katia, you're coming from a, you know, a couples perspective, couples therapy or sex therapy perspective. But do you have any tips for kind of those of us who are listening? How, like, are there phrases you use? Are there ways that you get partners involved, get them to open up?
I try to just make sure that I'm talking to them also during the visit, just so that they understand that they are in this conversation. Like I said, they're not a fly on the wall. I didn't just bring them in here just to be the arm piece of my patient. Like, I want them to have an active participation in this. And I think if you actually talk to them, then you'll notice that the walls will start breaking down and they'll start to feel more at ease and more comfortable. That's what I have found. But then again, like I said, you still have those patients who sometimes are like, absolutely not, no, hard stop. Then that's when I think they should go explore therapy.
Mm-hmm. All right. Okay. So just to summarize then, Shrita, it's like, so really, if the partner is there, paying attention to the partner,
yes,
you know, and having both be a part of the conversation, and probably some really simple questions to the partner about
just
her
ask them, like,
perspective and
what's her perspective like. So like when I'm going through like questioning, like if it's the first visit and the partner's there, if I'm asking the gentleman about his erections, then I will turn to the partner and just ask them, so like, how do you perceive the erection? And see if they feel comfortable with that. If not, then we can keep progressing and we'll keep trying to find a way to bring them into the conversation.
Good. Yeah. Okay. Yeah. Katia. Yeah.
Well, I'm thinking in my work and in my perspective, psychology, this is also an elephant that has to leave the room, but with very patience and a lot of modeling of the therapist, and this balance between the person that talks less, the balance of respect for the limits of the person, but also the expansion to flexibilize and to communicate what is needed to communicate and what's needed to say. So I'm thinking that in a first or second session, I will not be very intrusive about this. I will trying to break the ice and to try to make a very comfortable setting, interpersonal setting, and hear how we therapists are really modeling the communication, and probably the other person is very talkative and very dominant. So we have, I don't have a specific phrase, but if we notice that, we have to gently trying to nivellate and be genuinely interested by the person that talks a little bit, doesn't talk too much, and to ask simple, open questions, not very specific because it can be very intrusive, and hoping that the process will open a little bit. And then I'm thinking, if everything goes well, to talk about this characteristic about the person. So it's very difficult for you. I noticed that it's very difficult for you to talk about how you feel or how you think about this, or probably I'm guessing that they are not very cooperative in homework or other things that I may ask for the couple to do. So open questions, really validation also of the person, and trying in the other partner to deal with, probably we need to deal with expectations of that person won't be like a rock star of communication, probably, and that's okay. So expectations of the couple, and I think this is very important. We have to flexibilize, but people really, the structure, the psychological structure is our structure. So if I'm anxious, I'm always going to be more anxious, or if I'm less talkative, I will probably be less talkative, and my partner has to accept that also. But there is a common and a middle ground that we have to find. And I think that the therapist here is very important, because he's going to trying to balance the both of them in a session, and being empathic, and also being careful not, I usually say this in a second session. Probably some of you will hate me in one session, because you will think that I will take part of one of the members of the couple, or it's normal for people to feel that if they are vulnerable. So I anticipate sometimes things that I preview, and when it happens, it's more easy to talk about it. Oh, you are on our side, on his side, or okay, do you think that's okay? Let's talk about that, because it's not really where I am, but somehow this is here, so let's talk about it. So yeah,
good, yeah. And so, maybe one more question. We might be able to get one more question here, and this is probably something that comes up for both of you at some times. Is that, sometimes sexual function, is situational, right? So, and a man can have ED with a wife, but not with, let's say, a partner outside of the partnership, right? And so what are your thoughts, solutions? How do you work with that? Any suggestions?
Yeah. So yeah, that's a difficult one to kind of deal with.
I saved the hardest for last.
Thank you. I appreciate it.
For last. Absolutely.
I appreciate the pun too. But the thing is that I in my practice, I really try hard to figure out what is the underlying cause of your erectile dysfunction, right? Because the last thing I want to do is like do some medical treatment on somebody that they don't even need. So I really work hard to try to ask questions, try to figure out what it is. And usually I can figure out if it seems like it's situational. If it's situational, if I think it's more of they're just anxious with one partner over another, then sometimes I'll give them like a low dose PD5 just to help them build their confidence up. If it's something else, then that's when I'll send them to a therapist. Or I try to talk to them a little, like, again, occasionally I'll put that therapist hat on, but I'm really quick to take it off. I know my lane, and I have somebody in my area that I do send patients to, and I will send them to that person, just because at that point it's outside of my realm. That's not what I trained in. And I think they're going to need some more help to get over that situational erectile dysfunction.
Yeah. Good. Yeah. Katya. Yeah, any thoughts?
When this man comes to me, when Sharita came, sends it.
Yes, when I was in
support there. Yes, exactly.
And here, this is it's a difficult situation, and psychologists are very redundant. I don't know if this word really is in English, but we repeat ourselves because there's no other way. So what is the main goal of this person? It's to, because here we have the mix of sexual and relationship factors. What happens to this man when he doesn't have erectile function with one person and as with others? We have to evaluate all the factors. We have to be very specific and we have to find the links, and we have to find the triggers, and we have to be very specific about it. And then we have to find out what is the main goal of this, because if we need to bring the partner, we have a secret, so it's a problem. If the person wants to be in individual therapy but wants to reconnect with one of the partners, we have to be very honest about how difficult it will be without the partner in the session. So it's kind of a negotiation with this person. What are the main goals? What are the main objectives? What is the history of this person and sex life and with these different partners? And then to find a protocol, an arrangement, a therapeutic arrangement that doesn't, that hopefully doesn't bring me ethic or other problems, and I can help. So yeah, that's but it's hard. It's very, very hard. But I'm thinking I'm thinking of one case that I'm seeing this week that appeared for me the first time, and it's very interesting because sometimes it's a conditional thing of it's our excitation is conditioned, and then this person is divorced, is in a new relationship, he really likes the relationship, but he didn't have sex as with his wife. He doesn't have the same excitation or the same pleasure, and he doesn't want to be with his wife again. That's clear for him. So I find it very curious how things shift. We assume that things will go in one way, and then people bring us different shifts. Like, I don't want to be with her, but I didn't have. So, and he has a lot of vulnerability factors for a psychological ID, erectile dysfunction. He has a lot of that because he's,
Sure. Yeah,
he doesn't feel the same way. Yeah.
Mm-hmm.
So he has to make a reconditioning of his excitation to a lot of things, and to work a lot with thoughts and emotions and his identity also. Yes, as a man and as a new partner, I think. Yeah.
Yeah, it's kind of interesting, almost the opposite, right? Kind of
yeah,
corrections with
yes.
with
I remember
with an
that.
ex-wife, and then,
when I saw the question, yes, because we assume. Yeah,
right, exactly, right. No,
yes.
Good. And so, so I think we're probably just come to our time, but Annamaria is going to say a few last words, but just before she does that, I just want to say thank you to our two presenters, Dr. Oliveira and Dr. King. Really wonderful presentations and wonderful discussions. And we so appreciate your time and joining us for the webinar. And so thank you very much, and look forward to seeing you two at conferences.
Yes.
kind of around the world, and talking some more and continuing the conversation. So Annamaria, I'll hand it back to you.
Thank you so much. I must say I really, really enjoyed this webinar. Thank you for a wonderful moderation, Chris, and like connecting the questions. And what I find so amazing about this webinar is that sex therapy and the partner is like the cornerstone of sex therapy and sexologist working. And penile prosthesis is also the cornerstone of many urological ways to treat erectile dysfunction. So how this has been so elegantly combined by the excellent talks by you, Dr. King and Dr. Oliveira. This was really, really wonderful. So thank you so much for this contribution and taking your valuable time. So having said this, I just want to thank all the audience. We have been people from all continents, and you can see in the chat that people really enjoyed this. So I just want to invite you to our next webinar, which will be in June, and will be on another very interesting topic, BDSM in clinical context, guidelines for professionals. So this is really something new too, and this is so exciting. Can I have the next slide? I don't think we have more slides. No. So the reason why I asked for another slide is I also want to invite you to go to our webpage and see that we have our world meeting in North America in Miami in October. I hope to see many of you there. And also our webinars will be available very soon on YouTube. So Lillian did send out the link in the chat, but please go to the webpage. You can find the webinars. Also, if you're not a member, and if you're not a member, maybe you want to become a member after this excellent webinar. And thank you to all of you, and hope to see you in June 25. Take care.